Thank you everybody for being with us. And this first seminar on a series of seminars on mathematical modeling of COVID-19. This is sponsored by a project of UNAM, the PAPIT grant that we got in an effort of the National University to help in the control and mitigation of the epidemic that we have all over the world, and particularly in Mexico. There were 12 projects approved. One of them, one in mathematical modeling, is this one. And it's a joint collaboration between the Facultad de Ciencias with Dr. David Sanders, Institute of Physics with Dr. Isaac Perez, and Institute of Mathematics of myself, Jorge Velasco. Then this is the introduction. This is the reason we're here. The other one is about the talk. The talks are organized in 50-minute talks, followed by a series of questions and answers. These questions and answers will be, the questions will be written in the chat that is available to you. And so either of us, which is Isaac, David, or me, can relay the question to our speaker tonight. And, or you can raise your hand. There is a little icon there that you can also use in order to the question. Other thing is that the opinions given by the speakers are those of themselves. This is no, the UNAM position is independent on that. This is important because, as you know, COVID is a political issue too. And we want a meeting in which we have respect, openness. Questions, technical questions are the openness that scientific endeavors require, but we ask respect and to concentrate on the specific aspects of the talk so we can get a nice interaction with our speaker. Of course, we abide to the lines or the concepts or the principles of respect, of ideas, openness, no discrimination, will be no, that's a policy. And the other one is an important one. Zilang was a co-author recently of a letter in Science talking about the transparency, the promotion of free exchange of ideas, core sharing, peer review, for all things that have to do with modeling of COVID, because that's the only way we can get together ideas and models and tools in order to fight this disease. This is the general terms, and now I'll go to present our speaker. Is Dr. Zilang Feng. She's an extraordinary researcher. She's a professor at the mathematics department of Purdue University. She's also recently program director of the program in mathematical biology, National Science Foundation, I think from last year, beginning last year. She been very active in this. I read in SIAM that they have sponsored several grants specifically for modeling COVID-19, and it's a pleasure to have her here. She has more than 100 journal articles, 3 books, one of them on plant herbivore systems, I think, and most of them in mathematical epidemiology. One of them a very important monograph on the applications of mathematical models to public health, which is very relevant in these days. She's an expert in many infectious diseases, particularly influenza-like infections. So tonight, Zilang honors us by giving the first talk, and the title of the talk is Staggered Release Policies for COVID-19 Control, Costs and Benefits of Relaxing Restrictions by Age and Risk. So Zilang, the screen is yours. Thank you very much.
Thank you, Jorge, for the nice introduction. And thank you, thanks to the organizers for inviting me to give this talk. And this is a joint work with Henry Zhao from Princeton University. And we all know that strong social distancing restrictions, including lockdown, have worked for containing the spread of COVID-19 pandemic, but now has been an important question is to identify safe strategies to go back to normal or at least subnormal social interactions and restart the economy without jeopardizing public health. And this work focuses on identifying a strategy that can allow certain people, certain groups of people, to return to social interactions first before the general population is released. and we call this staggered-release. So we'll present examples that can show that this sequential release or staggered release by groups and the risk can do better than the simultaneous release of the general population, in the sense that they can protect more vulnerable people and increasing economic activities. This figure is sort of an illustration of what can happen if you put strong restrictions first, for example, from time t0. So from this time, you start intervention, control policy. And then the epidemic curve will change from this dotted curve, which is the epidemic without any intervention policies, to this thick curve that reduced not only the peak time, but also number of infections. But then after a period of time of the strong, say, social distancing policy, and you want to relax this strict policy at a time t end. And if you just release everyone at same time, even though you may still have some kind of social distancing policy in place. For example, here I said the SB, so that's for kind of severity in terms of the strength of social distancing restrictions. So B for beginning. So at this point, you have SB restriction, but at T end, you release that policy to have a new level, say SR, R for residual period, and say the level, the number between 0 and 1 representing the strength or severity of restrictions. Okay, the value equal to 1 represent the normal, the business as usual. And then if this value is, 1, yeah, the higher value represent stronger restriction, and the smaller value represent more relaxed. And so we can see that what happens that you were likely to see a second wave with the peak that might be high enough to exceed this healthcare capacity, which is could be very bad. So the question is, can we figure out a strategy that will allow people to return to work or school as early as possible, but safely? So that's the goal of this study. And I forgot to mention that this is actually a published work. It's published in Mathematical Biosciences. It's published in June 13. If you're interested, I can send you the PDF. And how do we identify such a policy? This figure shows the current situation for COVID-19 in the United States. It's a number of new cases up to July 29th of this year. And we can see that total cases past 5 million and total deaths is above 160,000. And this is for the whole United States. And in some states, the situations are more severe. For example, in Texas, Florida, or Arizona. And in Texas, in the early July, it said that the ICU capacity was exceeding 100%. So that could be very dangerous. And in Florida and Arizona, also in July, their daily new cases exceed 10,000. Okay, that was higher even than the record previously held by New York. And if we look at the specific states, so this figure is from Johns Hopkins University, the website about COVID-19. You can see all states in the United States, the curve, the incidence curve. And some states have pretty low incidence. Some states have much higher. For example, New York City And the higher peak occurred actually earlier in April. But for Florida, Texas, or California, or Arizona, you can see the recent rise in the cases. Okay. If we zoom in those states, okay, California, July 29th, the highest daily cases was more than 11,000. Okay. Similar for Florida, more than 11,000, and in Texas. So New York, they had highest peak in April. So it shows that it's still important to change this sort of, the way of going back to business, right? This is probably a lot of people, they have a higher risk. For example, people with underlying medical conditions or elderly people above 65 and so on. So if they are infected, they may have to go to the hospital or ICU and then could die from the infection. So if we look at this age-dependent, either hospitalization rate or disease death, we can see clearly there's much higher hospitalization rate for older people, 65 or older. There's a red curve. You look at the younger one, the yellow and the black, between 0 and 4 or 5-17, they are much lower in terms of hospitalization rate. Okay, so they may still get infected, young people. It just they don't get the severe infections using hospital or even die from disease. And from this figure, we can see the disease mortality, right? Also age dependent. This for older people, the red, yellow, and the blue, 65 or older, and versus the younger people, 0 to 24, 25 to 34, there's a light blue or the blue, they are much lower. So this suggests that maybe we can take advantage of this age dependent disease mortality or hospitalization rate to identify a releasing strategy. Okay. And for this paper, we consider this New York City, the population in New York City, because they have more detailed age-dependent parameters. For example, this figure, this is from their website, New York City, COVID-19 data. This is actually June 9th. That's when our paper was submitted. And you can see that the cases, hospitalization, and the deaths, okay, for older people, 65 or older, they have much higher hospitalization rate and disease death rate than the younger people, 0 to 17 or 18 to 44. And you can see the case fatality ratio for elderly could be even as high as 40 times higher than the younger group. So we want to take advantage of this difference in the disease mortality and hospitalization to construct a model. This is California. Similarly, you can see the age-dependent death rate. So our model is this SEIR type, but including other factors relevant to COVID-19. For example, this asymptomatic class. Okay, those are the people who are infected, but they do not show symptoms. But for COVID-19, those people can still transmit the disease, and even at pretty high transmission rate. So susceptible, exposed, symptomatic, asymptomatic, and the hospitalization is H. And from the hospitalized people for this class, they can die from the infection or they can recover. It's similar for the symptomatic people or asymptomatic, they can all recover. But asymptomatic people will assume that the death rate can be neglected. And this model, this corresponding ODE system, corresponding to this diagram, we have 3 age groups, okay, based on the age dependent, this data structure, okay, 0 to 17, 18 to 44, and then the middle age and the older group. The reason we combine the first 2 groups is that if you let the people, say young adults, go back to work, but the young kids cannot stay home alone, so if those adults go back to work and those students also should go back to school. So we combine those 2 groups together, called the young group, 0 to 44, And not all those young people, but only people with low risk. If some young children with underlying medical conditions, they are considered high risk, and they'll be grouped together with the more vulnerable older people. Similar for middle-aged people, for only low risk, they call the group 2, and the higher risk people will be grouped with this elderly. And this the M class, that's for dead people, people died from the disease. Okay, this is an important class because we're going to use this to compare policy, compare the staggered release policy with this simultaneous release policy, and to see whether or not this staggered release can reduce the disease deaths more. And in the forced infection, lambda, that's the term that linked the 3 groups. In this forced infection, so all 3 infected classes, symptomatic infected and asymptomatically infected and hospitalized people, they can all transmit the infection, but maybe at a different rate. For example, theta J for the asymptomatic people is going to be less than 1, okay, with a certain proportion, similar for chi. And the Cij here is the mixing. It is describe the context between different age groups. Okay. And A here, we call it effective contact rate. It's different from the normal contact rate, because normally we have contact rate multiplied by the probability of infection per contact. Okay. But that would include another parameter. So to avoid the estimation of more parameters, we just lump them together, called the effective contact rate. Okay. So that's contact that can lead to infection. Okay. But later on, I'll just refer this to as a contact rate for easy reference. And this mixing, okay, we're going to use this so-called preferential mixing. Okay. And the epsilon is the preferential level. That means that for group I people, if they have a certain number of contacts per unit time, a certain proportion of those contacts will be with other people in the same group. Like, for example, for children, young people, they probably spend most time with the other people at school, okay, than with maybe older groups. And the specific parameters in here, and the remaining contacts will be distributed among all groups according to this sort of a proportionally distributed. Okay. And this kind of mixing, okay, we have published several papers on this, all kinds of mixing, including preferential mixing. Okay. So this graph shows the sort of data in the Moissan, published in a sort of survey data, how certain group, age group people will distribute their contacts. For example, the main diagonal represent contact for people with other in the same group. So the lighter color represent that the more contacts will be with other people in the same group. And we can fit this function, this preferential function, into this data and to estimate this preferential level, epsilon, for example, and other parameters. And this data also give us this baseline, the contact number, A. And then you can see that the observed, this data versus the modeled, they have pretty good match. And we have applied those mixing function in different modeling studies, including influenza, pertussis, measles, and so on. Okay. So at least a couple of references here. So we can just choose those values, for example, epsilon in this study, so we don't have to do other detailed fitting. And then the important parameter will be this effective contact rate, because the social distancing policy, okay, you have restrictions. That means that the contact rate will be reduced. Okay. Stronger restrictions, correspond to lower the contact rate. So the contact rate A will be dependent on time. And this A0I is the background, it's a baseline contact. That's the, you don't do anything. Don't do any social distancing. That's the contact number. And that is related to the basic reproduction number by this formula, assuming that we know all other parameters. For example, gamma is for recovery rate, and P is proportion of asymptomatic infection. Theta is the reduction of transmission by asymptomatically infected people. So we know, if we know all those parameters, and then if we have estimates of R0, then we will get this A. And then once we have a background A0, we can define the effective reproduction number according to given social distancing policy, defined this way. Here, SB again represent the severity of restrictions. S equal to 1, corresponding to no contact, the most strict ones. And S equal to 0 means business as usual. Okay, it is no restrictions. And we have a different time period. For example, so this T0 is the beginning time when the restriction starts. Okay? And we call the initial period. And then at time T1, you will change policy. You can change this restriction level. For example, if you want to relax it, you let people go back to business. And then the timing will also be part of the policy. And then maybe at the T2, you change the policy again. For example, the first period, you let only group 1, the young people, out. Sorry, I apologize. This SB, this all 3 groups follow the strict policy. Okay. And then at T1, you let young people. Okay. The subscript represent the period, and the superscript represent the group. You let group 1 out because they have a lower severity. Okay. Until T2, you let the group 2 also back to social interactions. And then at the T end, all the groups will be released. Okay. That's the residual period with the severity level as 4. So we're going to consider different policies determined by the severity parameter S and the time where policy will be changed. Before we consider this situation, we're going to look at a simpler case where only group 1 will be released earlier. Okay? So the top figure represents this simultaneous release. Okay? That's the benchmark release, meaning that all groups will be kept at the severity level SB for the initial period of time until T end. All groups will be let out at the severity level SR. Okay, this is a benchmark release policy. So we're going to consider the difference between the staggered release policy with this benchmark release policy, and to see how this disease death will be affected, and how the epidemic curve, the peak of the epidemic curve, will be affected. And the bottom curve, the B, represent the one scenario of staggered release. Okay. So from T0 to T1, initial period, all 3 groups will follow this SB level of restriction. And from T1, we release the restriction for group 1 at this some level between SR and SB. Okay. And after T end, all 3 groups will be released at the level SR. Okay. So for presentation purposes, I'll assume in this talk, SB is 0.8. So the initial, the strict social distancing policy corresponding to SB with 0.8, sorry. And after the residual period, the restriction level SR will be 0.2. So basically, after you release everyone, you still want to keep certain level of social distancing, not just go back to business as usual. Okay, the results. So in this figure, we show 4 different time variable T. So T is the time when you start releasing the younger group, okay, T1. Okay, we have T1 with 20, 30, 40, and 50, okay, representing 4 policies. And for the restriction level, S21, we consider 5 different levels, 0.4, 0.5, 0.6, 0.7, 0.8, and the 0.8 represent the benchmark. Okay, so you see the dark black curve representing the benchmark scenario. Okay, you just let everyone out at the T end, that will be this epidemic curve, okay, with that kind of level of peak size. But if you look at the S21 equal to 0.4, so the restriction level for group 1 is 0.4, and the red curve will it is the epidemic curve. So basically, you have higher infections, okay, in comparison with the black curve, the benchmark case. But after T end, okay, so at this point, all groups will have 0.2 level of restriction, and to continue this epidemic curve, we will look at this red one. Okay, so overall, this red curve will have a much lower peak size, and in the next slide, we'll see that the total number of deaths will also be reduced by a lot in comparison with the benchmark policy. So this is kind of non-intuitive in the sense that, you know, you let people out first, okay, in comparison with the benchmark. How would it be possible that you reduce the number of deaths and peak size, right? So I put in here just sort of kind of heuristic argument. Okay. Suppose that after residual period, we have activity level AR, okay, for all group, and the gamma is the infection recovery rate. So AR over gamma gives you the control reproduction number. Okay, control means you still have social distancing, control reproduction number. But with a different severity, the superscript S, the number of recovered people at the T end, number of recovered people at the end, this proportion is the population level of immunity. Okay. So 1 minus that proportion will represent the proportion of population still susceptible. Okay. So the actually effective reproduction number corresponding to the severity level S is the control reproduction number here multiplied by this factor. Okay. That's less than 1. Okay. So if you look at this red curve, because more people are infected before T end, so your population immunity is higher. So remaining proportion susceptible will be lower. And that's why the effective reproduction number for the red curve after this point will be much lower. Okay, so that leads to much lower infection rate. Okay. And the reason for the lower number of deaths is because those infections are all low risk young people. Okay. So they have very much lower disease mortality and hospitalization rate. Okay. And that advantage of this releasing young, low-risk people first. If we look at this disease deaths, we use this quantity, okay, the total number of deaths under the benchmark policy, DBI, for group I, minus the total number of deaths for group I under the staggered release policy. Okay, the difference divided by the benchmark disease, so we call it efficacy. Okay, so that represents the level of reduction in disease deaths. Okay, the higher this FI, the better the policy will be. So the total number of deaths, you integrate the number of deaths from hospitalized people plus number of deaths from the symptomatic class, okay, integrate from T0 to infinity. So that's give you total or cumulative number of disease deaths. Okay, so, and this figure again shows those policies for T1 between 20 and 50, for the severity level for younger group between 0.4 and 0.7, and then the benchmark, the DB corresponding to S21 equal to 0.8. Okay. And you can see that all this efficacy for the group 3, which is the older group, they're all positive, and also the reduction is highest corresponding to severity level equal to 0.4. It's the most relaxed policy, and also at the earlier time, T1. And for F0 is a sum of all F, F1, F2, F3. That's the overall death. Okay. The reduction is also positive. Okay. Again, corresponding to S21 equal to 0.4, you get the highest reduction in these deaths. So this shows again the benefits of the staggered release, okay, of the younger group, younger people with low risk. And if you look at the efficacy for group 1 and 2, you observe similar reduction. If you have a lowest reduction because young people, they already have very low disease death. Okay. So overall, the staggered release policy will lead to lower number of disease deaths and lower number of lower peak size for the epidemic. But the timing and the severity level could be very important. Now, if we talk a little bit about parameters, choice of parameter values. Okay. So this again, this is New York City cases, hospitalization, and the death. Okay. We know the population structure for different age groups, a certain percentage, and with that, and we also know the hospitalization rate and the disease death rate. Okay. From those, we can estimate the parameters eta. The gamma is from knowledge. Okay, people usually assume that this infection period is anywhere between maybe 5 days, 7 days, 7 days, 10 days, or even 14 days. They're all different. But later we look at the sensitivity. Okay, if we choose different values of the infection period, how that would affect the outcome. So this is for the other parameters. And for R0, the R0 relates this background activity level. For R0, we have this from literature. Most papers assume R0 to be between 2 and 3, but this study by Shench in the published in Emerging Infectious Diseases, they actually estimate this reproduction number to be 5.7 with a 95% of confidence interval 3.8 to 8.9. So that's much higher than this most cited range, 2 and 3. So we actually have this, we use the New York, again, the case data. Okay. If we fit this just one group, okay, you ignore the age dependence, just one group with a percentage of symptomatic 0.7, so assuming 30% asymptomatic, again, this parameter may also be changing according to CDC published values. And we assume that the reduction for asymptomatic infection is 0.5 in comparison with the symptomatic people, the infection transmission rate. And then, so estimate the 8 and the Q previously, and the latent period, 10 days, the infection period is 7 days, and the duration in hospital set 10 days, so fix all others. And then we fit this model to this case data. We get this R0 to be 3.4. Okay, give the relative reasonable fit in terms of the number of cases. This is 100 number of cases in New York City. And then we can get the baseline A0. And once we get A0, we can get this AT, which is the effective reproduction number corresponding, effective contact rate corresponding to the severity level restriction SB. And the relationship between the group reproduction number R0I and the total reproduction number for the meta population, for the set population, is determined by this next generation matrix. Okay? And that will relate this baseline contact number. And this T is dependent on all those disease related parameters. Okay? And mixing Cij. Okay? This way. And the largest eigenvalue of this matrix is the group whole population reproduction number. So that whole population has this reproduction number R0 as some kind of weighted average of the group reproduction numbers weighted by those mixing parameters. So this 3.4 for the whole population corresponded to different reproduction numbers for the, each age groups. So before I continue to talk about other scenarios, here we summarize the results so far. First of all, this staggered release can increase the efficacy or reduce the disease death in comparison with this simultaneous release. And the level of efficacy increases with the decreased severity level. And that's what we observed so far. And the peak size is the highest for intermediate value. It's the lowest for intermediate value of the severity level. So that shows the importance of identifying the correct restriction. Okay, when you release the younger group, what is the most appropriate level of relaxation? And also the timing can be important. And so that shows that staggered release policies can protect more vulnerable people and lower the peak size and increase economic activities because it allow a certain group of people to go back to work and school earlier without increasing the public health negative, jeopardize the public health. Now, in terms of sensitivity analysis, okay, we show those results for fixed group of parameters. If we change some of the parameters, and one is this actually more generalized release, staggered release. We allow both younger group 1, the early release first, but at some point T2 will release the middle age group, okay, the second age group with this level. And then all groups will be released at the SR level. If we do that, then we can see that the efficacy, again, depends on the level of the severity and the timing, T2. Okay. The overall result is that releasing the middle age group first, earlier than the older people, can still do better in comparison with this simultaneous release. But the timing and the level of severity can be important. So that's the general finding. And if we increase the reproduction number, okay, from 3.4 earlier to 4.6, okay, so we know that reproduction number is some sort of average, right? It can vary between populations. Okay? For example, in New York City, the reproduction number probably much higher than place like Wyoming. Okay? That population density can play an important role. Okay, sorry, I'm running out of time. But in any case, this shows that similar observations in terms of the peak size and the total number of disease death reduction, again, the staggered release can do better than simultaneous release. But again, the timing and the severity level can be important. And this slide shows if we change this younger group, this disease mortality, if it's not as low as like in your city or other data shows. If you increase the younger group mortality, what will happen is the younger group will have a negative efficacy, meaning that their death rate will be increased. So this is some kind of a cost of releasing young people earlier if their mortality rate is relatively higher than what we presented in early examples. So again, we have to be very careful. And the last slide, I think it's the second to last slide, this shows that if we change the proportion of asymptomatic infections, okay, from 0.5, 0.6, 0.7, 0.8, and change this infection period, okay, using 7, 8, 9, 10 days, and we can see that the reduction of the death or the efficacy, they are still positive, it's just at a different level. Okay. But the general results that staggered release can reduce mortality, can protect the vulnerable people, at the same time, let people out earlier to increase the economic activities. So those conclusions remain. It's just a level reduction can be different. Okay, this shows some kind of robustness of this result. Okay. So in summary, this modeling studies presented some counterintuitive results. I explained earlier. You release younger people earlier, then the benchmark release policy, but you can still reduce not only the death rate in the older people, the vulnerable people, but also the overall population death. And the idea of this staggered release policy can do better is because you let low risk people to go back to work or school, and they can help build up the population immunity. Of course, the best way to increase population immunity is by vaccination, but before the vaccines are available, and this could be one way to increase population immunity without increasing population death. And again, this timing and the severity level, the control of the severity level can be very important, okay, in order to guarantee that the staggered policy can have a positive benefit. I think that's all, and I would like to thank support from NSF. Again, the point of view represent my own viewpoints, and doesn't represent NSF, and also collaborators Henry Zhao, Zhao, and useful comments and suggestions from Simon Levine and Carlos Chavez. Thank you.
Well, thank you, Silan. Very nice talk. I guess we go into questions. I don't know, Silan, you can look at the chat.
Yeah.
The questions are.
Yes.
Or you can call.
Yes, I think there should be two ways. One way is people can write on the chat.
Mm-hmm.
As far as I recall, maybe somebody can confirm this. I think in the chat there should be an icon saying raise your hand. I don't see it, but maybe it's because I'm host. But
you go to the participants list.
In the participant list. So let me see.
Oh no, that's not right.
It's not right. Yeah. So maybe we go through
the chat.
Oh yes, no, it is. Yeah, it is. No, it is in the participants list, right?
Is it?
Yes, the host can't raise the hand. That's why you don't see this.
Yeah.
Okay.
Oh, sorry. Yes, I just yeah. Sorry, somebody had their hand up and I lowered it by mistake. Sorry. So please raise your hand again. But yeah, so maybe somebody can just read out the questions that were.
Yeah.
I can do it.
You do it, Isaac, or?
Yeah. Go
Okay,
ahead.
Go ahead.
Yeah.
Go ahead. You do.
Okay, so let me ask the first question. The first question by Luis Mochan via the chat, and he asked the following. He's curious about the factor 0.95 that multiplies the severity when you have something like 1 minus.
Yeah. Very good question. Yeah. Yes.
The reason behind that number.
Yes. Yes. I forgot to explain this. So 0.95 just means even though you have a highest restriction, right? No contact. It still doesn't mean that you absolutely no contact, right? You cannot achieve the goal of no contact. So that just the 0.95. Just the most you can get. The reduction is 0.95. So you still expect some level of contact. So that's what 0.95 represent there.
Okay, very good. Another question by Luis Mochan, who says that can the release timing be chosen when only poor data is available, as for instance in Mexico?
No,
go ahead.
No, I don't think this I mean, data, of course, is helpful. For example, you can identify the point where this population immunity is sufficiently high, right? That will help to protect the older people. That's what data can help. But in general, in this study, there was no data used when those different policies are explored. Only in the beginning, when you try to fit some parameter values, we use the data, right? But this, see, we just choose this T to be 10, 20, 30, 40, 50 in the range, and the reduction level to be between 0.4 and 0.8, because the 0.2 is the final, right? The residual stage. Okay, you have to have a restriction level higher than 0.2. So we choose 0.4. Actually, you do 0.3. Sometimes you see the higher disease death. So that suggests that 0.4 is the better one, the safe, right? Because you don't want to increase the disease deaths by releasing people earlier.
Mm-hmm. Okay.
Yeah, but the data would help you to identify sort of safe moment to release.
Yes. Yeah, very good. And a third question, which is actually a question that I have myself by Alejandro Vargas Casillas. Mm-hmm. Given the model parameters, have you tried to perform an optimization procedure to find the optimal staggered release times?
Oh yeah, that'd be interesting. We haven't done that. We have not done that yet. So this study, so we just want to get this published soon. So just to make it known that there's a potential way of letting people out first, right? The staggered release. Okay. So basically, we just presented several scenarios to demonstrate that staggered release can actually help. Okay, more helpful than the simultaneous release. But yeah, optimization problem could be very interesting, actually.
Yeah, I agree. Okay.
Yeah.
We have many questions. People are very interested in the chat. Another question by Daniel Sagun. It says that is this model based on the absolute immunity developed by positive cases, or does it take into account recent learnings about partial immunity, which seems to be cases of COVID-19? I think that there is a controversy about this. I don't know, that maybe when you get infected by COVID-19, you don't get full immunity, but partial one. Is this taken into account?
Silan, I think
we lost her.
A transmission problem. Yeah.
They don't get a permanent immunity or complete immunity, and antibodies may not be 100%. So actually, it is possible to study, maybe allow the R to go back to S, maybe like a immunity loss, right? Temporary immunity. The immunity can wane, or they will get some level of immunity, but may not be complete. So did that answer the question?
Yeah, I think so. Yes. Mm-hmm. Yeah. So there was a bit cut of the video, but I think that the idea is like if you have partial immunity, then in the model you can put
back to S
susceptibles, and then of course staggered release would be less effective, but still more.
Or you can allow the R people to be some level of susceptibility, right?
Mm-hmm. Yes.
Either that, or just move some people back to the. Okay. Yeah. Depending on how complicated you want your model.
Yes, very good. Another question is from Fernando Roberto Momo, that says, how about the problem of young people living together with old people? How to relax restrictions only for young people?
That's very, very good questions. Right. So this obviously, that factor has been ignored, right? Young people, if they're infected, certainly they kind of bring this kind of, the problem to the older people. They live together, right? But if they don't live together, probably younger people should be careful, right? And they don't, just stay away from the more vulnerable people, right? That's one way. Or you can make the model more complicated, right? And I've seen people using that, more complicated models to study related problems. But the goal of this study is to make a simple model, as simple as possible, and then to demonstrate this point of the staggered release.
Yeah, very good. Right. Now, Mariana, I just saw you. I'm going to I noticed that you raised your hand in the participant list. I'm going to you are on mute already. Okay, I think you can ask question yourself, Mariana. Go ahead.
Yeah, so in fact, it's Sebastian. Sorry.
We are together.
Yeah, we are together. Sorry. So I have a question just about the fact that so your model is to see what is optimal way to go back to business, considering just the number of dead people. And I would like to know if you can easily not modified, but had an information, an economic information about which kind of contribution to the PIB is given each kind of group of people considering the age, and to convert this information with a model to offer to the state two kind of models, one which is optimizing the number of deaths and one which is optimizing the number of deaths, but with considering the PIB you recover with the back to business of the people.
Mm-hmm. Yeah, that also sounds an interesting problem to study. Again, so you are thinking about the optimization kind of problem, right? Or because this approach is this work is not exactly optimization, because they did not identify optimal one, right? We're not minimizing the death, right? They just identify this certain scenario can lead to lower deaths, right? That's different from you minimizing. You find the optimal one, right? That's a different kind of problem. But obviously, it will be very interesting if we can. So the reason I say if you don't have a good constraint, you say minimizing a problem, then of course minimizing. So the minimization will be just people don't go out. You stay home, complete cut off the contact. Your deaths will be smallest, right? If that's the minimizing solution, then that's not what we are looking for, right?
Yeah, totally agree. That's the reason why of my question is because the people, so the countries want to release the people just to have money. In fact, it's just an economic problem here.
Right.
So that's why I was asking if it's possible to add the information of the economical impact of each kind of age group, just to have another kind of scenario taking into account not just the number of deaths, but
you are thinking about like a money wise, like how much it would cost if you got infected, right?
Altogether, because in fact the politics are just interesting on the two. In fact, most of them are just interesting on the economical part. But if you can find a scenario which is not optimizing, but a scenario which is providing a very good result in terms of number of deaths, good economic.
Right, but then probably that you need to get more detailed. For example, a certain type of job, you go by to work. What kind of economic values that will be created, right?
That's true.
Yeah.
Mm-hmm. Right.
Okay. Okay. Very good. Next question. I'm trying to see whether I have all of them right. I'll do the last three, right? Which is the following. Alejandro Del Corano is asking the following. The cutting edge groups that you have from 0 to 44, 45, 64, and 60 plus, does it work for any country? So I guess that depends on the data on the country, right?
Right, yeah, so this, you can split the population any way you want. The reason we split this way is because that's what New York City data is in that form, right? So if you have a different country, different population, your data is presented in different cutoff in terms of age groups, right? Some data, most data probably report like every 5 years in one group, right? In a demographic sort of structure, 0 to 1, and then to 5, and 10, 15, and so on, right? And whatever data you have available, I think you can just take advantage of that.
Yeah.
Because eventually you want to estimate the parameter, for example, hospitalization rate, right? Disease deaths, right? And you estimate those values based on this data, right? So it doesn't have to be 44, right? It also depending on, I don't know, some countries, maybe parents are younger, right? So basically you want to have the flexibility that if you have those parents to go back to work and their children need to have daycare or something, right? Cannot stay home alone, right? Just that kind of consideration. And here, 65 and older, they opposite have a higher disease death rate. That's a good cutoff, right? For most vulnerable people, and I don't know, some population was the cutoff for older people is 60, right? It just depends.
Yeah. I guess it depends on the data you have for a given country and the
right
distribution that you have. Okay. Luis Mochan has another interesting question, which is the following. So let me translate. So what about having an alternating release? So for instance, so say that a part of the population works a given period of time, let's say a week, and then it rests and is isolated, and then the other part of the population, a certain proportion of the population works while the other part is isolated. Is this a good and viable strategy? So have you...
But why? Why do you want to rotate? Why do you have to keep the other group home? Just, you know, what is the motivation? What is the objective of doing that? Right. So right now we want to increase economic activity. That means that you let people go back to work, right? But if you keep one group out and then change to another group, why? Why do you want to do that? Is it because you are trying to reduce number of infections because fewer people out? Or
the idea, as I remember when I read about this idea, is to have the two populations separated from each other, and after working for a week, if you get infected, you will stay at home and not work 15 days later when it's your turn again. So it gives you time to find out if you have been infected during the week that you worked. So it was proposed by some groups, in Israeli groups.
I guess that's probably different level of complexity. But in any case, if people are infected, they should stay home, right?
Yeah.
Yeah.
But then when they are more, so they will stay home and not go back to work, right? But they will stay during the period when the infection develops. They would be at home anyway, so they won't be infecting anyone else.
Yeah, but why do you keep the other group home when they're not infected?
Since you don't know if they are infected or not after about a week goes by. So that's the reason you keep them home for a week. And then if they're not infected, they go back to work for a week. And then you keep them home again for a week and observe, so they can be observed.
I see. You just want to make sure they have enough time to find out whether they are infected.
Yeah.
Right. But have economic activity at the same time.
Yeah, I guess that'd be interesting, right? That I guess what would be interesting to compare if you do that versus without doing that, right? What do you save, right? how many, either in terms of death saved, or infections? If people don't die from it, don't create the hospital like a crisis, like increase the public health capacity, cause the overloaded public health system, then infection is not, I don't know how to say this, right? It's not, it's just like a flu, right? You get infected if it caused the damage, long-term damage, of course, it's not good. But if not, then it's just like a mild, people without even knowing it, and then they just recovered. And that's I don't know, that's just trade-off, right? You are able to go back to work earlier, and with infection that are not even serious. Just as it's hard to compare which one, just without doing analysis to see which one is better. Okay, again, when you say better, you have to define in what sense.
Okay,
Thank
so Luis, did she answer your questions?
Yes, I have to think about it, and I guess we have to compare, right?
Yeah, it is definitely an interesting scenario to study, right? But only if they can do better. Otherwise, you are just coding people away from the economic activity.
Yes, yeah. So I think so. Let me do just one more question, okay? And then we'll leave it for today. So Mariana Vargas is asking. So this the following: this age-dependent preferential mixing needs to be calibrated for each country, right?
This one, yes. So this data from Moson study as a polymod data, they have from European countries. So this gives you kind of pattern, and you had to apply it to your specific population, right? So we applied it to US population, then you had to, usually when you have this contact matrix, you had to balance it. So make sure your group I total number of contacts and the group J total number of contacts must balance. Okay, you had to work before you can use this mixing data. But so that at that step, you can use your specific population.
Mm-hmm.
Yeah.
So very good. So Jorge, shall we leave it for today?
Yes, I think. Thank you very much, Silan, for your very interesting talk. As you see, there is a lot of interest here in Mexico about the problems you are attacking and what is happening around the world. So thank you all for being here. And we continue with the seminar in 15 days. And our next speaker is Esteban Vargas. I don't remember.
I think so.
Esteban Hernandez. Well, we will let you know. And please distribute and inform everybody that we have an interesting seminar if you like it. And we see you next in 15 days. Thank you, Silan, again.
Thank you.
Josefa says hi. Bye.
Bye.
Bye. Thank you.
Thank you.
Bye. Saludos.
Bye, bye.
Adiós, Jorge.
Saludos. Hasta luego.
Que estén bien.
Igualmente.
Stop.